Okay. Tell me if you're complete. And the one who will share, tell me if you're complete, and the one who will share the presentation may share screen. I will stop sharing. You may start when you're ready.
Jenny, can you make it in a PowerPoint mode so that it will be enlarged, and you can start now.
Now is it clear?
Okay.
Yeah.
Good afternoon. Welcome to our small group discussion with regards to normal labor and delivery. So anyone can be called upon for participation and for any input. Okay, as much as possible, aim that everyone would have a part so that everyone would have a break. All right, proceed.
Okay. Good evening, Doc. Today we would be discussing normal labor and delivery. So here are our members. So firstly, to define labor, it is the process by which the fetus is expelled from the uterus. More specifically, labor requires effective contractions that leads to dilation and effacement of the cervix. It is associated with pain, suffering, trouble, or body exertion. So the indications for good progress of labor are good dilatation and good effacement. The indications that labor has started are painful contractions plus the rupture of the membranes. The features will either be bloody or watery discharge. Bloody show in which the blood is mixed with mucus, mucus plug that is found in the cervical canal just before the actual labor starts. And there is also complete cervical effacement. The difference between the true labor and false labor is that in true labor, contractions occurs at regular intervals, wherein in false labor, it occurs at irregular intervals. In true labor, it occurs every 5 minutes. And if taken early labor, it occurs every 15 minutes. And if taken at early phase, it occurs every 3 to 5 minutes. And the interval is gradually shortened, whereas in false labor, it remains long. The intensity also increases, whereas in false labor, it remains unchanged. The cervix dilates, whereas it does not dilate in false labor. And there is presence of discomfort in the back and lower abdomen. And in false labor, the discomfort is chiefly in the lower back. And in true labor, discomfort is not stopped by sedation and the labor will still progress, whereas in false labor, discomfort is usually relieved by sedation and the contractions will eventually stop. And the sedation will have no effect in true labor, whereas in false labor, sedation would relieve the discomfort. Lie refers to the longitudinal axis of the fetus relative to the longitudinal axis of the uterus. It can be, fetal lie can be longitudinal, transverse, or oblique. In a singleton pregnancy, only fetuses in a longitudinal line can be safely delivered vaginally. Presentation refers to the fetal part that directly overlies the pelvic inlet. In a fetus presenting in the longitudinal lie, the presentation can be cephalic, also known as vertex or breech. Compound presentation, this refers to the presence of more than one fetal part overlying the pelvic inlet, such as the fetal hand and the vertex. Phonic presentation, this refers to presentation of the umbilical cord and is rare at term. In cephalic fetus, the presentation is classified according to the leading bony landmark of the skull, which can be either the occiput, the chin, or the brow. Malpresentation, this refers to any presentation other than vertex, is seen in approximately 5% of all term labors. So here's the various depiction showing cephalic presentation. Diagram A shows the vertex, B is the sinciput, the C is the brow presentation, and D is the face presentation. And this is also a diagram of the landmarks of fetal skull for determining the fetal position. The attitude, this refers to the position of the head with regard to the fetal spine, the degree of flexion or extension of the fetal head. Flexion of the head is important to facilitate engagement of the head in the maternal pelvis. When the fetal chin is optimally flexed onto the chest, the suboccipitobregmatic diameter, which is 9.5 centimeter, presents at the pelvic inlet. This is the smallest possible presenting diameter in the cephalic presentation. As the head extends, the diameter presenting to the pelvic inlet progressively increases even before the malpresentations of brow and face are encountered, and it may contribute to the failure to progress in labor. The architecture of the pelvic floor, along with increased uterine activity, may correct deflection in the early stages of labor. Position of the fetus refers to the relationship of the fetal presenting part to the maternal pelvis, and it can be assessed most accurately on vaginal examination. So the diagram shows various fetal presentations and positions in labor. LOA, which depicts the left occiput anterior, LOP, the left occiput posterior, LOT, which is the left occiput transverse, ROA, the right occiput anterior, ROT, the right occiput transverse, ROP, which is the right occiput posterior. Station, it's a measure of descent of the bony presenting part of the fetus through the birth canal. The current standard classification, which is from -5 to +5, is based on a quantitative measure in centimeters of the distance of the leading bony edge from the ischial spines. So there are 4 phases of labor. So the first phase, the phase 1, which is the quiescence phase, this is the prelude to parturition. So in this, you would note contractile unresponsiveness and cervical softening. The phase 2, which is the activation, this is, it denotes a preparation for labor. And there will be presence of cervical ripening. The phase 3, the stimulation, denotes the processes of labor. In this, there would be uterine contraction, cervical dilation, fetal and placental expulsion. And the phase 4, which is the involution, denotes the parturition recovery. In this, there would be uterine involution, cervical breastfeeding. So these are the phases of the labor, starting from the quiescence to involution. So the first phase, which is the quiescence, this would represent the time in utero before labor begins, when the uterine activity is suppressed by the action of progesterone, prostacyclin, nitric oxide, parathyroid hormones, and possibly other hormones. And the activation phase, which is phase 1, In this, estrogen would begin to facilitate expression of myometrial receptors for prostaglandins and oxytocins, which results in ion channel activation, and this would increase the gap junctions. And so increased gap junctions between the myometrial cells, this would facilitate in the contraction of the uterus. And, also, the activation phase direct the uterus for the stimulation phase. And in humans, normally this process would occur over days to weeks. And the final phase, which is the involution phase, in this, uterine involution occurs after delivery and is mediated by oxytocin. So the phase one, which is the quiescence, represents a time in utero before labor, and is suppressed by the action of progesterone, relaxin, nitric oxide, PTH hormones, and other hormones. They function by different mechanisms, but in general, they increase intracellular levels of the cyclic adenosine monophosphate or cyclic guanosine monophosphate, which in turn would inhibit the release of calcium from intracellular stores or reduce the activity of the enzyme myosin light chain kinase. And calcium and MLCK are central to uterine contractility. Calcium is also required to activate calmodulin, which induces a conformational change in MLCK, allowing the enzyme to phosphorylate myosin and initiate the coupling of actin and myosin, which would lead to myometrial contraction. Rare uterine contractions that occur during the quiescent phase are of low frequency and amplitude and are poorly coordinated. These are commonly referred to as the contractures in animals and Braxton Hicks contractions in women. The poor coordination of these contractions is primarily due to an absence of gap junctions in the pregnant myometrium. The phase two is characterized by increased level of expression of contraction associated proteins, which includes the connexin 43 and receptors for oxytocin and stimulatory prostaglandins. Normally, the signals for myometrial activation comes from the uterine stretch as a result of fetal growth or from the activation of the fetal HPA axis as a result of fetal maturation or both. Signals for myometrial activation also comes from the fetal HPA axis. It is currently thought that once fetal maturity has been reached, the fetal hypothalamus and the placenta increase the level of the CRH secretion, which in turn stimulates the ACTH hormones expression by the fetal pituitary and cortisol and androgen production by the fetal adrenals. Fetal androgens are then aromatized into estrogens by the placenta. Ultimately, this would initiate a biological cascade that leads to a common pathway of parturition characterized by uterine contractility, cervical ripening, and decidual or fetal membrane activation seen in phase two of parturition. The early phase, which is also called the latent phase, is the longest and it normally would last up to 20 hours, especially for first-time mothers. Typical early phase of labor would start with contractions coming every 5 to 20 minutes, and it would last for 30 to 60 seconds each. Contraction pains are not as severe as compared to the active phase. At the beginning of the early phase, the contractions are milder, shorter, and irregular. And as the labor progresses, the contractions would become stronger, regular, and more frequent. When the contraction comes every 5 minutes, it is time to visit the hospital. During the early phase, the cervix opens to about 3 centimeters, 1 inch. As the cervix begins to open, a sticky jelly-like pink or slightly bloody discharge called show may come out of the vagina. This is the mucus plug that blocks the cervical opening during pregnancy. The active phase is when after the cervix dilates to around 3 centimeters, the active phase of labor would begin. In this, contractions become more stronger, more painful, and it would occur every 2 to 3 minutes without much time to relax in between contractions. The cervix would start dilating faster and it would become open till about 8 centimeters, which is 3 inches. The baby's head would descend further and further into the pelvis. And if it hasn't already, the water would break and the mother would experience pressure in the lower back. The transitional phase, during this phase, the cervix would open to about 8 to 10 centimeters, which is the diameter needed for the baby to pass through. Contractions would become more intense, occurring every 2 to 3 minutes and lasting for 60 seconds or more. At this time, the leg may cramp and the patient may feel shaky and nauseated. Some women would choose to receive pain medication such as tranquilizers and regional blocks like epidurals. The baby's head continues to descend more into the pelvis, and by the end of the transitional phase, a birth canal would have been formed. This is a single passage of the open womb, cervix, and vagina for the baby to pass through. So this graph shows the characteristics of the average cervical dilation curve for nulliparous labor. So for nulliparous, during the latent phase, the lower value is around 1 to 1.7 hours. The upper value is around 15 hours. The active first stage is around 1 hour, and the upper value would be around 19.4 hours. And in Paris, the latent phase, it's not yet studied. And for the active first stage, it's around 0.5 hours, and the upper value is around 14.9. And for nullipar, the normal value is the normal duration is around 6.4 hours, more or less between 5.1 hours, and if prolonged, it is greater than 20 hours. And in multipara, it's around 4.8 hours, and if prolonged, it's lasts more than 14 hours. So for phase 3, this involves a progressive cascade of events that leads to common pathway of parturition involving uterine contractility, cervical ripening, and decidual and fetal membrane activation. These events are characterized by fetal HPA activation, functional progesterone withdrawal, increasing maternal and fetal estrogens, and rising prostaglandins. The cascade may begin when the placental production of the CRH and eventually leads to a functional progesterone withdrawal in the myometrium. The progesterone withdrawal would cause increased levels of expression of estrogen receptors and promotes estrogen activity. This would further lead to the formation of many estrogen-dependent gaps such as CX43 oxytocin receptors and prostaglandins that would promote uterine contractility. During cervical ripening, there would be cervical changes that would precede the onset of labor, and they're gradual and they develop over several weeks. It is normally characterized by a decrease in the total collagen content and increase in collagen solubility and increase in collagenolytic activity that results in remodeling of the extracellular matrix of the cervix. Hormones like prostaglandins, estrogens, progesterones, and inflammatory cytokines would affect the metabolism of the extracellular matrix. Uterine contractility would result from coupling of actin and myosin, which depends on the phosphorylation of myosin by the myosin light chain kinase. MLCK is activated by calcium calmodulin after an increase in intracellular calcium levels. This increase is generated by the actions of various uterotonins, including oxytocin and prostaglandins. Cell-to-cell coupling, which allows the myometrium to develop synchronous high-amplitude contractions during labor, is facilitated by the formation of gap junctions and their associated proteins. The decidual and fetal membrane activation, this refers to a complex set of anatomical and biochemical events that result in the separation of the lower pole of the membranes from the deciduas of the lower uterine segment and eventually in the spontaneous rupture of membranes. So the phase 4, this would begin with the third stage of labor, and it would involve placental separation and uterine contraction. Placental separation would occur by cleavage along the plane of the decidua basilis. Uterine contraction is essential to prevent bleeding from the large venous sinuses that are exposed after delivery of the placenta and is primarily affected by the oxytocin.
So the cardinal movements of labor. So the mechanisms of labor, also known as the cardinal movements, refer to the change in position of fetal head during its passage through the birth canal. Because of the asymmetry of the shape of both the fetal head and the maternal bony pelvis, such rotations are required for the fetus to successfully negotiate the birth canal. Although the labor and birth comprise a continuous process, 7 discrete cardinal movements of the fetus are described. The one is engagement, then the descent, flexion, internal rotation, extension, external rotation, and restitution, and the expulsion. So the engagement, it refers to the passage of the widest diameter of the presenting part to the level below the plane of the pelvic inlet. The cephalic presentation with a well-flexed head, the largest transverse diameter of the fetal head is the biparatal diameter, which is about 9.5 centimeter. And in the breech position, the widest diameter is the bitrocandric diameter. Clinically, engagement can be confirmed by palpation of the presenting part, both abdominally and vaginally. With a cephalic presentation, engagement is achieved when the presenting part is at the zero station on vaginal examination, and engagement is considered an important clinical prognostic sign because it demonstrates that at least at the level of the pelvic inlet, the maternal bony pelvis is sufficiently large to allow the descent of the fetal head. In nulliparas, the engagement of the fetal head usually occurs by 36 weeks gestation, and in multiparas, however, engagement can occur later in gestation or even during the course of the labor. Descent, it refers to the downward passage of the presenting part through the pelvis. Descent of the fetus is not continuous. The greatest rates of descent occur during the deceleration phase of the first stage of labor and during the second stage of labor. Then the flexion. Flexion of the fetal head occurs passively as the head descends owing to the shape of the bony pelvis and the resistance offered by the soft tissues of the pelvic floor. Although the flexion of the fetal head onto the chest is present to some degree in most fetuses before labor, complete flexion usually occurs only during the course of labor. The result of complete flexion is to present the smallest diameter of the fetal head, the suboccipitobregmatic diameter, for optimal passage through the pelvis. Then internal rotation. It refers to the rotation of the presenting part from its original position as it enters the pelvic inlet to the anterior-posterior position as it passes through the pelvis. As with flexion, internal rotation is a passive movement resulting from the shape of the pelvis and the pelvic floor musculature. The pelvic floor musculature, including the coccygeus and the iliococcygeus muscles, forms a V-shaped hammock that diverges anteriorly. As the head descends, the occiput of the fetus rotates towards the symphysis pubis, thereby allowing the widest portion of the fetus to negotiate the pelvis at its widest dimension. Owing to the angle of inclination between the maternal lumbar spine and the pelvic inlet, the fetal head engages in an asynclitic fashion. With uterine contractions, the leading parietal eminence descends and is first to engage the pelvic floor. As the uterus relaxes, the pelvic floor musculature causes the fetal head to rotate until it is no longer asynclinate. Extension. Extension occurs once the fetus has descended to the level of the introitus. This descent brings the base of the occiput into contact with the inferior margin of the symphysis pubis. At this point, the birth canal curves upward and the fetal head is delivered by extension and rotates around the symphysis pubis. The forces responsible for this motion are the downward force exerted on the fetus by the uterine contractions, along with the upward force exerted by the muscles on the pelvic floor. External rotation, also known as the restitution, refers to the return of the fetal head to the correct anatomic position in relation to the fetal torso. This can occur to either side depending on the orientation of the fetus. This is again a passive movement resulting from a release of the forces exerted on the fetal head by the maternal bony pelvis and its musculature and mediated by the basal tone of the fetal musculature. Then the last one is the expulsion. It refers to the delivery of the rest of the fetus. After delivery of the head and external rotation, further descent brings the anterior shoulder to the level of the symphysis pubis. The anterior shoulder is delivered in much the same manner as the head, with rotation of the shoulder under the symphysis pubis. After the shoulder, the rest of the body is usually delivered without the difficulty. So as you can see in the picture, the first one is of Jenny, can you just before engagement, and the next picture B, it shows the engagement in the zero station and flexion with descent. So the third picture shows the descent and rotation as the baby is rotating, and the D, it's complete rotation and early extension. And the picture E shows the complete extension of the head, and the F shows restitution. The head is mostly delivered. And the last anterior shoulder delivery, and then the posterior shoulder delivery, which will lead to expulsion of the baby. Then this is a Friedman's curve, which shows the dilatation of the cervix and also the descent of the baby through the birth canal, through it based upon the stations, the pelvic stations, whether it is at the 0 position or -1, like that. Next slide, please. Assuming the diagnosis has been confirmed, what are the expectations for the prognosis of a normal labor? So the Friedman's curve, which will help us to know whether the baby can be delivered by vaginally. So this is a scientific approach was begun by Friedman, who described a characteristic sigmoid pattern for labor by graphing the cervical dilatation against time. And Friedman developed the concept of 3 functional labor divisions to describe the physiological objectives of each division, as shown in the figure in the previous slide. So the first, during the preparatory division, although the cervix dilates little, its connective tissue components changes considerably. Sedation and conduction analgesia are capable of arresting this labor division. The dilatational division, during which dilatation proceeds at its most rapid rate, is unaffected by sedation. Last, the pelvic division commences with the deceleration phase of cervical dilatation. The classic labor mechanisms that involve the cardinal fetal movements of the cephalic presentations take place principally during this pelvic division. In actual practice, however, the onset of the pelvic division is seldom clearly identifiable. The pattern of the cervical dilatation during the preparatory and dilatational divisions of the normal labor is a sigmoid curve. 2 phases of the cervical dilatation are defined. The latent phase corresponds to the preparatory division and the active phase to the dilatational division. Friedman subdivided the active phase into acceleration phase, the phase of the maximum slope, and the deceleration phase. And in the latent phase, the onset of the latent labor, as defined by Friedman, is the point at which the mother perceives regular contractions. The latent phase for the most women ends once dilatation of 3 to 5 cm is achieved. And this threshold may be clinically useful for defined dilatation limits beyond which active labor can be expected. Prolonged latent phase. Friedman and Sachtel-Benz defined this by a latent phase exceeding 20 hours in the nullipara and 14 hours in the multipara. These times corresponds to the 95th percentile. Factors that affect latent phase durations include excessive sedation or epidural analgesia, unfavorable cervical condition, that is thick, uneffaced or undilated and false labor. Then the active labor.
Roy, please
Yes,
summarize your slides. Do not just read it. So that you could process what is important. Okay?
Okay. So in the active labor, there will be a rapid change in the slope of the cervical dilatation, which means that from 3 cm where the initial dilatation was, then it will be like rapid, so that there will be a rapid change in the dilatation of the cervix so that the baby can be delivered easily. And for the descent begins in the later stage of active dilatation, commencing at 7 to 8 cm in nullipara and becoming most rapid after 8 cm. Next slide. So these are the stages of labor. In the first stage, begins with the onset of regular contractions and end with the complete dilatation. So that complete dilatation, which means around 10 cm of the cervical dilatation, and stage of expulsion begins with complete cervical dilatation and ends with the delivery of the fetus. Then the third stage is the placental stage, begins immediately after the fetus is born and then when the placenta is delivered. And the fourth stage is maternal homeostatic stabilization. So after the delivery of the baby, we have to check whether the mother is having a postpartum hemorrhage, and we have to observe the mother and continue. This stage continues from the 1 to 4 hours after the delivery. So this is just an illustration of the stage 1, stage 2, and the stage 3. Next slide. So the first stage of labor, contraction to the full dilatation. So we have to perform a fetal admission test. We have to check whether the fetus and the mother can tolerate the labor, and usually done with a vibroacoustic stimulation to see if the fetus will react to the bell. Normally the fetus will have acceleration and no deceleration. So then we have to check what is the fetal lie and the presentations and the fetal pole, etc. So it will be done through the Leoploid maneuver. So the first one is the Pelvic Grip. So the examiner faces the maternal head and grabs the uterine fundus. So and identify what fetal pole does the fundus occupy. So if it is a cephalic one, the fetal head is round and hard, it will be able to grasp. But if it is a breech one, then it will be like more nodular, softer, and not able to grasp. Next slide. In the second maneuver, which is the umbilical grip, which gives us information of the fetal lie, so that the examiner same faces the maternal head and grabs the sides of the abdomen with the palm of the both hand. That is why it's called as the umbilical grip. So determine which side the fetal back is or other part. So that if the fetal back, then it will be like flat and firm, which can be used to assess the heartbeat of the baby. Next slide. The third maneuver is called as the polygraph. So the examiner same faces the maternal head, using the thumb and fingers of one hand grasps the portion of the maternal abdomen just above the symphysis pubis and determine the engagement of the fetal part. So if it is if the head is engaged, then we will not be able to we will feel like a fixed mass. But if it is not engaged, we will feel like it's a blood floating part. So that we will be able to know that whether head of the baby is engaged or not. And the last one is the pelvic grip, or the fourth maneuver. So the examiner for this time faces the maternal feet and grasps with two hands the sides above the symphysis pubis. So it determines the fetal attitude and degree of the fetal extension, so that they will know whether the fetal back is extended or the fetal small part is in flexion, and we will be able to locate the fetus brow. Next slide.
Vaginal examination. Discharge. Note if watery or bloody. Watery is a amniotic fluid. Bloody, it's a hemorrhagic complication. Done unless there is bleeding, excess of blood is shown. May trigger more bleeding. Avoid anal region. Vaginal exams and cervical dilation. The number of vaginal exams depend on how far the cervix is dilated. 1 to 2 centimeters can send them home. 5 to 6 centimeters more or less in the active phase. The status of the bag of water, the nature of the presenting part, position of the presenting part by identifying where the contils are, determine the station of the presenting part. Detection of ruptured membrane. During speculum examination, you see pooling of fluid into the fornix and get a sample of the fluid. Normal, it is 4.5 to 5.5. Amniotic fluid, it is greater than 6.5. Cervical assessment, cervical dilation. Estimating the average diameter of the cervical opening. 10 centimeters fully dilated. One finger is 1 centimeter, two fingers is at least 3 centimeters. Cervical effacement. Initially, the cervix is long, labor progresses, it becomes shorter or the canal becomes obliterated. Normally, the length of the cervix is about 2.5 to 3 centimeters. It can be subjective when the length of the cervix is reduced by 1/2. It is 50% effaced. So if the cervix becomes as thin as the adjacent lower uterine segment, it is 100% effaced. Cervical position. Normally, the cervix where the mother is almost at labor, the cervix would be directed anteriorly. If mother has false labor, the cervix would be directed posteriorly. Cervical station. Identifying the landmark, which is ischial spine. If the presenting part is 1 centimeter below the ischial spine, the station is +1. If the presenting part is 2 centimeters above the ischial spine, the station is -2. The Bishop's score, it is to access cervical favorability. The cervix, the position, consistency, effacement, dilation, station. At the score 0, the position is posterior, consistency firm, effacement is 0 to 30%, dilation close, station is -3. At 1, it is mid position, consistency is medium, effacement is 30 to 50%, dilation 1 to 2 centimeters, and station -2. At 2, the position is anterior, consistency is soft, effacement is 60 to 70%, dilation is 3 to 4 centimeters, and the station is -1. At 3, the effacement is greater than 80%, dilation is greater than 5 centimeters, and station is +1 and +2. The Bishop scores, you should add 1 point for preeclampsia each previous vaginal delivery and subtract 1 point for post-date pregnancy, nulliparity, or premature preterm rupture of membranes. Additional factors is 0.1 for each previous vaginal birth or -1 for the first time birth givers. Add the score for each factor. Score lower than 5 suggests labor will not be begin without induction. Score 9 and higher indicates labor will likely begin spontaneously. Scores 3 and lower may indicate that an induction would be not successful. Contraction. Place palm lightly over the fundus. Before it was just the hand that monitors the strength of the contractions. Now we have the fetal monitors that note the strength of the contractions. Check for duration, intensity, and interval. Fetal well-being. Using a stethoscope, check the fetal heart tone after contraction. Low-risk patients listen every 30 minutes. High risk every 15 minutes. Oral intake for low risk, easily digestible food, sips or of clear liquids, ice chips. Intravenous fluids. Only if it is necessary in mother, seldom necessary until analgesia. An intravenous infusion system is advantageous during the immediate perineum to administer oxytocin prophylactically and at times therapeutically when uterine atony persists. Longer labors, the administration of glucose, sodium, and water to otherwise fasting women at the rate of 60 to 120 ml per hour prevents dehydration and acidosis. Laboratory hemoglobin. A mother in labor always needs a baseline hemoglobin count because seemingly normal progress of labor may subsequently develop into hemorrhagic complication. That's hemocrit. Blood typing, urinalysis. Position during labor, supine, on the floor, squatting, sitting, standing, as long as there are no contradictions. These are the positions. Analgesia depends on the need and desire of the participant, depends on the patient threshold of the pain threshold of the patient. Amniotomy. Occasionally puncture the amniotic sac to check the character or consistency of the amniotic fluid. Fetus is having changes in the fetal heart tones. You may use to puncture to see if it's clear or meconium stained. When there is hypoxia, if fetus is asphyxiated or there is poor oxygen supply. Timing. Proper time is in between contractions. If preferred during a contraction, the pressure is so high and the bag of water is tense, you can trigger a sudden gush of fluid which might take with it umbilical cord. Bladder function. Avoid bladder distension. This could lead to obstructed labor and subsequent bladder hypotonia and infection. Bladder is just beneath the lower segment of the uterus and it can be in a way and can be traumatized once the presenting part starts descending. So we want the bladder empty because of the pressure of the fetus. The pelvic nerves which supply the bladder can be constricted or pressed upon and you can have problems of bladder subsequently. First stage summary is admit. Admit, make sure they are in true labor. Diet depends on the status of the advancing labor. Monitor contractions and fetal heart tones. IV fluids if anesthesia is required. Therapeutic measures, analgesia. Women are admitted if active labor defined as cervical dilation of 3 to 4 centimeters or more in the presence of uterine contractions and is diagnosed or if ruptured membranes are confirmed. Stipulate that a pelvic examination be performed at approximately every 2 hours. Ineffective labor is suspected when the cervix does not dilate within 2 hours of admission. Amniotomy is then performed and labor progress determines at the next 2 hours evaluation. In the women whose labor do not progress, an intrauterine pressure catheter is placed to access uterine function. Hypotonic contractions and no cervical dilatation after an additional 2 to 3 hours result in stimulation of labor using the high-dose oxytocin regime.
Second stage of labor, dilation to the delivery. Management of second stage of labor, preparation of the delivery. Dorsal lithotomy position, most satisfactory position to increase pelvic outlet diameter. Maternal expulsive efforts, it can be spontaneous because once the head presses on the rectum, it produces a reflex. It is something you cannot control whether she likes it or not. She will continue pushing. A woman is not encouraged to push beyond the completion of each contraction. Instead, she and her fetus should be allowed to rest and recover. When you coach them, you tell them to take a deep breath and then push. You try to monitor the progress or descent of the presenting part. Bulging of perineum with further distant overlaying skin becomes tense and glistening. Fetal heart rate. Low risk fetus auscultation every 15 minutes. High risk fetus every 5 minutes of interval. Episiotomy, incision of perineum. The characteristics and type of episiotomy. There are two types, midline and mediolateral. For surgical repair, it is easy and more difficult in mediolateral. Faulty healing is rare and more common in mediolateral. Postoperative pain is minimal and common in mediolateral. Anatomical results are excellent and occasionally faulty in mediolateral. Blood loss is less less in midline and more in mediolateral. Dyspareunia is rare in midline and more occasionally in mediolateral. Extensions are common in midline and uncommon in mediolateral. Delivery of the head. Crowning. Encircling the largest head diameter by the vulval ring, the perineum thinsen, especially in nulliparous women, may undergo spontaneous lacerations unless an episiotomy has been made. To limit spontaneous vaginal lacerations, some perform intrapartum perineal massage to widen the introitious for head passage. The perineum is grasped in the midline to both hands using the thumb and opposing fingers. Outward and lateral stretch against the perineum is then repeatedly applied. The return maneuver done if expulsion efforts are inadequately or expeditious delivery is needed. Procedure: gloved finger beneath and draped towel exert forward pressure on the fetal chin through the perineum just in front of the coccyx. Concurrently, the other hand presses the superiorly against the occiput as shown in the figure. Delivery of the shoulders. Most often, shoulders appear at the vulva just after external rotation and are born spontaneously. If delayed, extraction aids controlled delivery. The sides of the heads are grasped with two hands and gentle downward traction is applied until the anterior shoulder appears under the pubic arch as shown in image A. Next, by the upward movement, the posterior shoulder is delivered as shown in image B. During delivery, abruption or powerful phase is avoided to avoid brachial plexus injury. Hooking the fingers in an axilla is avoided. This can injure upper extremity nerves and produce transient or possibly permanent paralysis. Traction should be exerted only in the direction of long axis of the neonate. If applied obliquely, it causes neck bending and excessive brachial plexus stretching. Slide your hand on the back of the fetus and grasp the ankles so that you will secure the baby. After the baby is out, place the baby on top of the abdomen of the mother for early skin-to-skin contact. Next slide. Clamping of the clot. Wait for the cord compression to stop. Delay cord clamping may also hinder timely and needed neonatal resuscitation. For the preterm neonate, delayed cord clamping has several benefits. These include following: higher red cell volume, decreased need for blood transfusion, better circulatory stability, lower rates of intraventricular hemorrhage, and necrotizing enterocolitis. Next slide. Focus on newborn care and vulnerable infant life within the first week. Wipe the baby with dry towel. Wait for cord pulsation to stop. Properly timed cord clamping. When preparing for delivery, don 2 pairs of gloves after thorough hand washing. Remove the first set of gloves. Palpate the umbilical cord. Wait until the cord pulsation has stopped. Clamp the cord 2 centimeters and 5 centimeters from the base and then cut between the clamps. Keep the mother and baby in uninterrupted skin-to-skin contact. If newborn is breathing or crying, position the newborn prone to the mother's abdomen or chest. Cover the newborn back with a dry blanket. Cover the newborn head with a bonnet. Use a warm cover if room temperature is less than 25 degrees Celsius. Generally perceived to be an intervention for provision of warmth and bonding. Focus third stage of labor. Fetal expulsion of placental suppression and expulsion. Suppression can be triggered by diminution in size of placental site after birth of the baby. After the baby is out, the cavity of the uterus becomes smaller, the placenta will double upon itself and the accumulation behind the placenta will begin. Signs of placental suppression. Uterus becomes globular, which is Calkin sign. Sudden gush of blood. Uterus rises in the abdomen. Umbilical cord lengthens within 1 to 3 minutes. Management of third stage of labor. Uterotonic oxytocin is induced 10 new intramuscular within 1 minute after delivery to prevent postpartum hemorrhage. Placental expulsion. After placenta has separated, it may be expelled by increased abdominal pressure. Completion of third stage is also accomplished by alternately compressing and elevating the fundus while exerting minimum contraction of the umbilical cord. It can be suppression either starting at the center where you have the body of the placenta coming out of the loosening structure. The other one can be starting from periphery. Inspection of the placenta. Spread out the membranes to look for extra vessels, lobes, or holes in the surface. Separate the amnion from the chorion by pulling the amnion back over the base of the umbilical cord to ensure both are present. Turn the placenta over to inspect the maternal surface. Episiotomy repair. The lacerations of birth canal. The first degree lacerations involves forceps, perineal skin, and vaginal mucosa. Second degree of laceration involve, in addition to skin, mucous membrane, the fascia, and the muscles of the perineal body or the anal sphincter. The third degree lacerations extend through the skin, mucosa membrane, perineal body, and the rectal sphincter. Fourth degree of laceration extends through the skin, mucosa membrane, perineal body, and rectal sphincter and rectal mucosa. This is the summary of the patient upbringing in the hospital. First, we'll be diagnosing the labor, followed by fetal admission test, and we'll check for vital signs, review of antenatal record, and a vaginal examination, presentation, dilation, effacement position, cervix station, followed by laboratory studies, monitor fetal well-being and uterine contractions, vital signs, amyotomy, urinary bladder function, and followed by second stage, prepare for delivery, check for sepsis, antisepsis, draping and position, Rinten maneuver, delivery of shoulder, wipe, and baby dry, notch cord delay clamping, oxytocin, and followed by placental delivery, inspection of placenta, repair and episiotomy if any, and check for vital signs, and followed by fourth stage of labor. Completed, ma'am.
Okay. Where is it? You have discussed adequately theoretical. So if you are presented with a case such as this, do you know what to do? So for example, a 23-year-old G3P3 came in with a chief complaint of regular contractions. You're the clerk at the emergency room. How will you manage this patient? What are the things that you need to know? Other people who did not speak during the reporting, speak up, please. Yes, go ahead.
Age of gestation.
Okay, age of gestation, what else?
Intensity and frequency of contraction.
Okay, intensity and frequency of contractions, what else?
Cervical effacement.
Okay, history. For PE, you look at your cervical effacement. You do your internal. Else I can help with? You do your internal examination. You have discussed your bishop's score quite adequately. So, although you forgot, what else is important in the internal examination?
Doc, any bloody or
Leakage
watery
of fluid.
Bloody or watery discharge. Okay, what else do you assess during internal examination?
Cervical dilation.
Else, you know your bishop score. What else is being assessed during your internal exam?
Pelvimetry, Doc.
Okay, your pelvimetry. So remember your pelvimetry. What would be the components of your inlet? It's just a review.
Sacral curvature, ischemic spine.
Your
pelvic
inlet is
sidewall.
composed of what? What is the only parameter for your inlet?
Sacral promontory.
Okay, your sacral promontory. So it will produce, if it's reachable, it's contracted. Okay. What would be the parameters of your, what are your parameters for your midplane? One is the prominence of your ischial spine. That's correct. What else?
Curvature of sacrum.
Saktivel, Rexon. I haven't heard from you. Russell Raj. Those who haven't spoken, please do. What are the components of your midplane?
The sacrum, pelvic side wall,
Okay, pelvic side walls. It should be what? Pelvic side walls should be what?
Parallel or divergent?
Okay,
Or-
should be parallel or divergent. Okay, what else? Your midplane, prominence of your ischial spines, your pelvic side walls. What else? There are two more.
Sacral, doc.
Midplane.
Sacroiliac
notch through.
Okay, your sacrosciatic notch, what should its parameters be? What should your sacrosciatic notch be?
It's 2 finger breadth.
Okay, it should admit 2 finger breadths. And what's the last parameter of your midplane?
Intraspinous diameter.
So your interspinous diameter should be
Greater than 8 centimeters. Though.
okay, more than 8 centimeters. Then going to the outlet, what are your parameters for your outlet?
pubic arc,
Subpubic ankle,
Okay, your pubic arc, which should be more than how many degrees?
19 degrees.
90 degrees.
90
19
degrees. Okay, what else? What
coccyx
else
If the
would
coccyx is movable or not.
your coccyx should be movable? And what's the last?
Intertuberous diameter,
Must be what?
8
greater than
centimeters.
8
8
centimeters.
centimeter.
Or admits a fist. Okay? So, of course, you have to make sure that you have a normal pregnancy. Check your vital signs, check your fetal heart tones. Okay? So, this is the internal examination. So, what's your next step? Cervix is 2 to 3 centimeters, 50% effaced. Midline, soft station, -2, ruptured bag of water.
Doc, we do the internal examination.
Doc, we admit the patient.
We admit the patient. For example, the bag of water is still intact. Would that make a difference?
Admit the patient and we need to give the tocolytics.
Well, it's already term. Why do you have to tocolyze? Maybe you're confusing it with your augmentation or your oxytoxics. Your tocolytics, it will prevent labor. Your oxytoxics, it will induce labor. Okay? So we will admit the patient because the bag of water is already ruptured. So if the bag of water is not ruptured, there may be room, for example, the patient just lives near. You may want to temporize and say, just go back when the labor is in the active phase. Okay? So this is what I want to stress to you. So during clerkship, this is what you will always see. For every patient admitted, we do a non-stress test. Do you remember what a non-stress test is for?
Is to monitor
monitor the heart
fetal
rate.
monitoring.
Okay. So what are the components of your non-stress test? What are the data that we could get from here?
Fetal
What
heart
are
rate.
okay, the first is your fetal heart rate. What should be the range of your fetal heart rate?
110 to 160.
110 to 160.
110 to 160.
160.
All right. Okay. What else? What else could this non-stress test give you? What other information?
Acceleration and deceleration.
As seen, it's acceleration and deceleration. So how do we define its pair? So it's a transient increase of greater than 15 beats per minute while your deceleration would be a transient decrease of greater than 15 beats per minute. So you should have 2 accelerations in a 20-minute trace. Okay? What are the other information that you could get from your non-stress test?
Uterine contraction.
Interbit variability.
Fetal movements.
Beat to beat variation.
Okay, beat-to-beat variability. So the change of your heart rate, normal would be how many?
5 to 25.
Okay, 5 to 25. Less than 5, you will say that it is minimal variability. 5 to 25 would be normal variability
Moderate
or
or
moderate
normal.
variability, and more than 25 would be marked variability. Okay, and the last component would be your
Uterine contraction.
uterine contractions. That's the one found below. So you should have contractions, at least 3 for you to say that it's adequate, more or less, in a 20-minute trace. How else is it measured? So it has to be at least how many Montevideo units?
200.
So this should reach at least 200 Montevideo units. In this case, so you have to reaching how many? 60. So there are 2, so 120. So you could not consider this adequate contractions. So this would just be mild to moderate contractions assessment. Okay? How will you manage the patient? Okay. I think you have assessed this, discussed this part very adequately. So estimated time of delivery of the patient. How do you compute? You have also reported the table of 1.2 and 1.5. Since this is a multigravid, so it will dilate 1.5 centimeters per hour. Okay. Things that you could do to augment, of course, your oxytoxics, as you have discussed appropriately. Okay. You have also discussed this. I just wanted to point out the non-stress test and your CTG tracing, because those are the things that you are missing on because we are not face-to-face. All right. Any questions for this afternoon? Could you open your cameras and Roy, could you document it and send it to my Viber as your attendance?
Yes, Doc. Everyone open your cameras.
Clerk and Garage, don't you have lighting? We cannot see your face.
Yes, Doc. Done with the screenshot.
You don't have your, okay. Thank you for attending. We may leave this call if there are no more questions. See you next SGD.
Thank you, Doc.
Thank you, Doc.
Could you send